Hello and good morning, everybody. I want to thank you for joining us this morning um, for the urinary tract infections in kidney patients. Just a few housekeeping slides. For those who don't know, the Kidney Foundation, we provide direct assistance to patients with kidney disease, provide education for the general public, um, and patients and their families. IO that provides that. All right. I'm not sure if you guys can hear me. I know we're having some connection issues. Are you able to hear me?
Yeah, we can hear you now.
Okay. Um, so at this time, I'm going to turn it over to Dr. Gundelly, who will be doing the presentation today. This is a webinar format, so if you have questions, please feel free to put them in the question and answer, and we will respond to those throughout the presentation. Thank you.
Thank you, Jennifer. I'll start sharing my slides. Okay. Can you see my slides? Probably not. Can you see them now, my slides?
It says that they're starting to share. I am not able to see it where I'm at, though. I'm having some issues with my connection.
Okay, let's see. Where am I? Okay, I think Erica says they can see them.
Oh, yep. Yes. Yep. So you can go
Mm,
ahead and start talking.
Okay. Okay. Are you able to see it in the presentation mode or?
It looks like you just have to start the slideshow.
Okay. Not sure. Something is missing. Ah. Can you see it now?
Yeah, it is in presenter mode.
Presenter mode. Okay, swap the things. And now, is it good?
Yep, it's good.
I'll change the thing. Sorry for that.
That's okay.
Okay. Okay. So, as some of you know, my name is Dr. Praveen Gundelly. I'm a transplant ID physician at University Hospital. And these are my disclosures. I don't have anything. So the main objectives for this talk are basically to describe the urinary tract infections in transplant patients, specifically kidney transplant patients. So, to describe the epidemiology and risk factors for developing the urinary tract infection, and then how to diagnose and manage these patients, and finally, how to approach a patient who has frequent urinary tract infections. Okay. So, at the University Hospital, we do about like 200 plus kidney transplants. And as there have been a good progress in the surgical techniques, and so the one of the most commonest problem with kidney transplants is infections, urinary tract infection. Almost, I can say that more than like 30 to 70% of patients will develop a urinary tract infection within the first year of transplantation. Uh, This can be avoided to certain extent, but it's not possible to prevent them 100%. And urinary tract infection is the most common cause of sepsis when these patients are admitted to the hospital. The other common causes of hospital admissions are like rejection or surgical complications. Surgical complications happen within the first few weeks or maybe 1 or 2 months after the transplant. But after that, the most common complications are infection and rejection. And the prevalence of urinary tract infection is highly variable. In one study, in Spanish study called Recitra, which followed about 4,500 kidney transplant patients for about 1 year, the incidence was 4.5 per 100 transplant days. That means like almost like 10, like there were like 10 infections in these transplant patients in up to 1 year. And the prevalence also ranges highly because the definition of urinary tract infection is highly variable. Sometimes patients might be called that they have diagnosed with urinary tract infection based on the urine analysis when they don't have any symptoms. In some patients, the diagnosis is based on like symptoms like fever or dysuria or other symptoms. And the definition also changes because some of these patients are also on prophylaxis. So when they are on prophylaxis, the incidence of urinary tract infection might be lower when compared to patients who are not on the prophylaxis. Whenever a patient comes to me for pre-transplant evaluation for some other reason, I always discuss the risk of urinary tract infection in these patients, what they can do from their standpoint in trying to minimize these risks. There are several risk factors. There is no one factor which can say that these patients are at the highest risk. There are a couple of risk factors. In general population, as we know, women are at higher risk for infections because of the shorter length of the urethra. But in transplant patients, in the first few months, men and women have like similar incidents. But after 3 years, studies have shown that women have more incidents of UTI. And other risk factors include diabetes. Someone who has uncontrolled diabetes mellitus is at higher risk for infection. And patients who have kidney stones or patients who have history of like pyelonephritis, like if their native kidneys have recurrent infections, those infections can persist in the native kidneys, which can later on lead to infection of the transplant kidney. And in men, the most important risk factor is prostate hypertrophy. As men get older, they have difficulty in urination and they can have urinary retention, which is one of the significant risk factor for developing frequent urinary tract infections. These are the general risk factors for infection and the transplant related risk factors. As you can see in this picture, the native kidneys are way high up here, and the transplant kidney is usually placed in the right lower quadrant or the left lower quadrant. The distance between the transplant kidney and the bladder, the ureter, is like very short, and there is no natural sphincter like our body has for native ureters. Here we have a natural sphincter which prevents the urine reflux in majority of people. But when it comes to a transplant kidney, there is no valve or something to prevent sphincter to prevent the reflex. So these patients are at higher risk for vesicoureteral reflex, which can cause infection of the transplant kidney. That's one of the significant risk factor. And the other risk factor is stenosis. Whenever the anastomosis is made, there can be stenosis, which leads to hydronephrosis and can cause UTI or sepsis. Other risk factors include urinary leak. If there is a urinary leak, that's another significant risk factor. And one of the other common risk factor within the first few weeks of transplant is a stent. If patients have a stent is needed to prevent stenosis. So most of the surgeons and most of the kidney transplant patients have a stent so that they don't develop a stenosis later on. But presence of a stent by itself can predispose the patients to infection. Fortunately, the stent is most often removed within the first 4 to 6 weeks. So that risk factor is eliminated in a lot of patients, except a few patients where they might still need a stent or a nephrostomy tube because of hydronephrosis, stenosis, or atonic bladder. The other risk factor in for the UTI is induction therapy with thymoglobulin. Several studies have shown that induction therapy with thymoglobulin, which almost destroys all the lymphocytes, causes UTI, then Simulect, which is a IL-2 blocker, which can also be used as an induction agent. So if a patient receives thymoglobulin, they are at a higher risk for infection because they have much weakened immune systems. And we should also know that all patients with end-stage renal disease, their bladder is almost atrophic and atonic because it hasn't been functional for anywhere from few months to several years. It undergoes atrophy. And once the transplant happens, it does not regain its function immediately. So patients who are on dialysis for a long time, they have difficulty with like emptying their bladder completely because of the atrophy of the bladder musculature. And the next aspect is the microbiology of these infections. A majority of infections, like general population, is caused by gram-negative bacteria. Gram-negative bacteria, most common we see is E. coli. But if it is hospital acquired or if someone has been on antibiotics for a long time, they can develop infections with Enterobacteriaceae members, Pseudomonas, Klebsiella, Proteus. These are the most common organisms. The organism depends on patient's prior history of infections, or is it acquired in the hospital, or if patient has undergone multiple urologic procedures. Like if a patient has undergone several urologic procedures prior to transplant, they are likely to be infected with highly drug-resistant organisms. So whenever a patient comes in with a UTI, most often we think of gram-negative organisms. There are a few gram-positive organisms which can also cause UTI. Among them, the most common is Enterococcus fecalis and Enterococcus faecium. These organisms can also cause UTI in a small majority of patients. Other organisms like Streptococcus, beta hemolytic strep, they can rarely cause, but it's pretty easy. And the most common antibiotics we use, like ceftriaxone, piptazo, they are effective against these Streptococcus species. Whenever we culture Staph aureus in the urine, we should always suspect a bloodstream infection because Staph aureus is not a usual urinary pathogen. If someone comes in with sepsis and the urine culture grew Staph aureus, we should always investigate if that infection is coming from somewhere else, like if a patient has a PICC line or if the patient has dialysis port or something like that, because Staph aureus rarely causes ascending urinary tract infection. The only situation we will see Staph aureus infection directly in the UTI is when they have like a stent or Foley catheter, chronic Foley catheter. How about some unusual causes of UTI? Every once in a while, we see like patients' urine analysis shows pyuria, but then the cultures are negative. Each lab is different in terms of testing for urine and the culture. So we need to be cautious about what we are trying to look in the urine. Let's say if we are trying to see, I mean, patient had multiple urine cultures, then they have been negative. So if we are suspecting something extraordinary or unusual, we need to inform the lab about it because these cultures are held for incubation only for 16 hours. So less than 1 day, they are incubated. If there is an organism which takes a little bit longer to grow, then we need to inform the microbiology lab. For example, if let's say we are suspecting like Candida, then we need to tell the lab that, hey, we are suspecting Candida, then can you incubate it for longer time? Or we can order a fungal screen, which is the same culture, which is incubated for a couple of extra days. And if we suspect like mycoplasma, then we can do a nucleic acid test. Mycoplasma, hominis, and ureaplasma, they are the normal genital flora. So detection of this organism does not necessarily imply they have UTI, but every often, depending on their immune status, if all the cultures are multiple urine cultures are negative, patient is symptomatic, then you can consider these organisms as infectious and can be treated. One other organism is Staphylococcus epidermidis. In the previous slide, I mentioned about Staph aureus. Staph aureus is different than Staph epidermidis. Staph epidermidis is a skin flora. So whenever a urine specimen is contaminated, it's very common to see Staph epidermidis, and it generally does not cause UTI, except when a patient has a urethral stent or a nephrostomy tube. If a patient has a nephrostomy tube and the culture is growing Staph epidermidis, then you need to consider it as a pathogenic organism. The other organisms which can cause UTI in but cultures will be negative is adenovirus. About a couple of years ago, we had a patient here at UH. Patient came in with gross hematuria and UTI symptoms. He had some sepsis, like he had some fever and dysuria, discomfort, and multiple cultures have been negative. Like 2 or 3 cultures were done in the hospital. But later on, we checked for adenovirus and it was positive. Fortunately, we did not need any treatment for him. With decrease in immunosuppression, his symptoms got better. The other viruses you can consider are cytomegalovirus. BK virus causes hemorrhagic cystitis in bone marrow transplant patients, but not really in kidney transplant. BK virus has been associated with urethral stenosis, but really it does not cause hemorrhagic cystitis like patients with bone marrow transplant, where it can cause massive hemorrhage from the bladder. And cytomegalovirus, we all treat it very well, and it's rarely a cause of uh, UTI. Occasionally, we can diagnose these viral infections based on pathology. Patient undergoes a biopsy for rejection or elevated serum creatinine, and then the pathologist does viral staining, and they say that, hey, this is positive for cytomegalovirus. Mycobacterium tuberculosis and other fungal infections are very rare, and we don't check for them often unless there is some clinical suspicion. How do we diagnose UTI? I can tell like sometimes it's straightforward. I mean, we don't have to do much. We know patient has kidney transplant, comes in with sepsis, and the urine analysis looks significant pyuria. In certain cases, it's difficult because some patients can have pyuria and positive urine cultures, but the reason the patient presented is for some other infection like a pneumonia or intra-abdominal infection. So whenever we evaluate a patient, we need to do a complete physical exam and history taking also just to see what are their symptoms and everything. A good number of patients, especially with kidney transplant, do not present with symptoms related to urinary tract. In general population, patients present with dysuria, frequency, pelvic pain. But whenever patients come to the hospital, most often they have non-specific symptoms of sepsis. For example, they might have like a fever, like fever of 101 or more, or they might say, I'm having rigors, which they call it as chills. But if it's rigors, we need to suspect like bacteremia. Other symptoms include like fatigue, vomiting, just a general sense of not feeling well. Whenever we suspect UTI, like some patients can present with these symptoms and we can do a urine analysis. It's very important to perform urine analysis prior to giving antibiotics because even with one dose of antibiotics, sometimes urine cultures will be negative, especially if the bacteria is highly sensitive, like a pan-sensitive E. coli. Patient gets one dose of antibiotic in the emergency room, and a couple of hours later, urine is collected, it will be negative. So we need to make sure that urine specimen is collected prior to giving antibiotics. And whenever a urine specimen is collected, we need to educate the patient how to collect it. Preferably, a midstream sample has to be collected. That kind of eliminates the little bit chance of contamination. Or if they cannot provide a good urine specimen, a straight catheterization can also be performed. It's not generally recommended to perform cultures from a Foley catheter. Guidelines do recommend to exchange the catheter and then perform a urine analysis and culture so that if there is any bacteria which is colonizing the catheter, they uh, don't like overgrow, or it can say like a mixed cultures. So what about patients who don't have any pyuria? Does it eliminate the diagnosis of UTI? Yes, in majority of cases, if a patient has a white cell count of, let's say, like 5 to 10, then it's unlikely that it's the patient has UTI, except when a patient has neutropenia. We have seen a couple of times like patient comes in with fever or other symptoms and their white count is less than 1, probably because they're on valsite or some other medication which causes significant leukopenia. So if their neutrophil count is very low, we can't expect to see a significant amount of white cells in the urine. So in those patients, UTI should still be considered. And whenever we suspect sepsis, blood cultures should be performed. Usually, blood cultures provide a very good diagnosis. Once the blood cultures get positive, we know what exact some because UTI sometimes we may not get a positive urine culture, and even if we get a positive urine culture, sometimes the lab may not report it as significant. For lab to report a urine culture as significant, it has to grow more than 10 power 5 colony forming units per ml. If there are like less than 10 power 5, then the lab might say insignificant colony. But if you specifically indicate that it's a transplant patient, they will still work up the fewer colonies grown on the culture plates. Classification of UTI. There have been like several classifications of UTI depending on uh, different societies. The classification here you see is by the American Transplant Society, which is classifies into asymptomatic bacteriuria, simple cystitis, complicated UTI, and recurrent UTI. Recently, IDSA, which is the Infectious Disease Society of America, they proposed a different classification. That's very simple. That's helpful in the treatment, not really in the diagnosis. So, what is asymptomatic bacteriuria? Asymptomatic bacteriuria means whenever sometimes urine culture is performed for other reasons. Let's say nephrologists perform urine analysis for to check for protein and the cells because they are concerned about like rejection or other causes. So whenever a urine culture grows some bacteria, but patient is completely asymptomatic, like no symptoms at all, no symptoms of sepsis, no localized symptoms of dysuria, or patient has a normal renal function, then there is no need to treat these urine cultures, except in the first 1 to 2 months of transplant. So usually, whenever patient comes to transplant clinic, like every week or every other week, the surgeons and nephrologists check it, but it should be limited only to the first 1 to 2 weeks, not more than that. This has been recommended by like several societies also. The next group is simple cystitis. Simple, many of the transplant patients, it's not simple cystitis. Only a few patients will present with simple cystitis. A good number of patients present with complicated UTI only because, as you can see from the previous slide, the location of the kidney and the bladder is very close by, and any infection in the bladder, it can go to the kidney. So a significant number of patients present with complicated UTI. A simple cystitis, patients don't come to the emergency room. Usually they call the kidney coordinator and say, hey, I'm having some frequency and dysuria. So in those cases, we can treat accordingly as an outpatient. But if a patient presents with fever, chills, then it's automatically considered a complicated UTI, and patients might need hospital admission to treat it. A recurrent UTI. Recurrent UTI is like having frequent infections. More than three or more infections per year is considered a recurrent UTI. We will discuss more about recurrent UTI approach later on in this talk. So, treatment, as I mentioned, asymptomatic bacteriuria does not need treatment except within the first 1 to 2 months of transplant. Simple cystitis, based on the antibiogram and based on the cultures, you can decide what antibiotics to treat the patient. The most common antibiotics we use are like cephalosporins, augmentin, ciprofloxacin. These are the common antibiotics, and treatment is usually for 5 to 7 days, no more than 7 days in simple UTI. But as I mentioned in my previous slide, most of these patients have complicated UTI. So once we diagnose a complicated UTI, especially depending on the location of the patient, most often they are in the hospital because they are already febrile and they can be bacteremic and septic also. In those patients, we have to use intravenous antibiotics, and duration is highly variable, anywhere from 2 weeks, and some authorities also recommended up to 4 to 6 weeks, depending on the clinical situation. This is just to show a few studies which say that treating asymptomatic bacteriuria is not helpful in transplant patients. Uh, Sometimes we as physicians treat asymptomatic urine cultures hoping that it would prevent a future UTI, but several studies have shown that this is not the case. So in this situation, when cultures are positive and patient is asymptomatic, instead of treating these patients, we have to educate the patient saying that treating with antibiotics at this time is not going to prevent a future infection. But at the same time, if the patient has symptoms, maybe 1 week from now or 2 weeks from now or later on, we have to tell them what are the signs and symptoms and when to call the coordinators or their physician for treatment. Uh, I had a couple of patients When I saw them, I tell them like, hey, you don't have any symptoms, no need to treat. But after 1 week, they'll say that, hey, I'm having symptoms now. So I think education plays an important role in managing asymptomatic bacteriuria rather than like upfront treatment. How do we approach a patient with recurrent UTI? Uh, This is the biggest problem I encounter in managing these patients because if it's one or two episodes of UTI, we treat the patients and they are done. But every often we have patients. I mean, I had some patients who present to the emergency room every month with bacteremia, despite being treated appropriately. So those are the very challenging cases. And in those patients, we can have a systematic approach to see if there is anything different we can do in preventing these UTI. In the next slide, I'm going to discuss what are the preventive strategies also. As I mentioned, if a patient has three or more UTIs per year, it's considered a recurrent UTI. The studies on the effect of recurrent UTI on the kidney graft have been highly variable, but many experts agree that if a patient has a recurrent UTI within the first few months, there might be long-term graft dysfunction. Because of that concern, we try to treat them aggressively and try to prevent these infections if possible. One of the first test we do in anyone presenting with recurrent UTI is make sure they don't have any bladder issues, especially elderly men. If they have like prostate hypertrophy or they can't empty their urinary bladder completely, we need to see, like, do a post-voidal bladder scan to see if they're retaining significant amount of urine or not. If they are retaining significant amount of urine, we can consult urology to see what are the intervention strategies depending on straight catheterization, Foley catheter, or sometimes using some medication to decrease this prostate hypertrophy. Once we perform a bladder scan, we have to evaluate for other abnormalities. First, next is like we can do an ultrasound or CAT scan to see if they have any structural abnormalities. Especially when we say structural abnormalities, it's usually like a ureteral stenosis, hydronephrosis, either a stone, this kind of structural abnormalities. If there is hydronephrosis stricture, usually transplant surgery does nephrostomy tube or a stent to decrease the risk of recurrent UTI. If there are no structural abnormalities, is voiding cystourethropy has been recommended. Not all the institutions perform this test routinely because the interventions we can do for this abnormality are very limited. Because if someone has vesicoureteral reflux present, surgery has been recommended. In one study, for like there has been a decrease in the incidence of UTI, but again, the authors mentioned that it is a very small study and so it cannot be extrapolated to all the patients. And these surgeries might be complex, and so many institutions and surgeons do not perform the vesicoureteral reflex surgeries. And if there is no vesicoureteral reflex, then you can, what are the other options we have to manage bladder dysfunction or outflow obstruction? If they have like a atonic bladder, they have to perform straight catheterization. That's the most common strategy many patients follow. Okay. And one of the common non-antimicrobial strategies I recommend is having them hydrate well and emptying the bladder regularly. That's going to like prevent the growth of bacteria in the bladder and thereby decreasing the incidence of UTI. Donor-derived infections. Rarely, donor-derived infections can happen in patients undergoing kidney transplant. Traditionally, all the urine cultures were treated. like historically, whenever the donor culture was positive, the recipient was also treated. But nowadays, there is a change in that practice because whenever a donor is positive, because the donor is sick or maybe like brain dead and they are fully catheter. So the it's very common to have colonization of the bladder of the donor. So, and that is not usually transmitted to the recipient, but it can happen. Even here at UH, we had a few cases where highly resistant bacteria have been transmitted from the donor to the recipient. Depending on individual case, we can treat the recipient. Routine because it's mostly the kidney and a small segment of the ureter is transplanted. And in the donor, mostly its bacteria is localized to the bladder. So the risk of transmission is low, although not zero, it's low. And the routine prophylaxis also helps in preventing these donor-derived infections. In the past, the preservative fluid was also cultured because once there were a few cases of candida transmission, so preservative fluid was also cultured. But treat, treatment based on preservative fluid is not helpful in all the patients. So this practice has been abandoned unless there is some extraordinary circumstances. So basically nowadays they don't perform the culture of the preservative fluid. I also want to talk a few things about UTI in general population because more or less it's the same with some few differences. This is the recent classification proposed by IDSA because the purpose of this classification is to make sure we don't, I mean, the studies can be compared head to head rather than like having different diagnoses, because when someone has a variety of like different diagnoses, it's difficult to compare the studies. So because of that, and also to have a uniform approach to treatment, classification has been simplified. Uh, In the newer classification, there are only two categories. One is uncomplicated UTI, and the second one is complicated UTI. In the past, uncomplicated UTI included only women, non-pregnant, premenopausal women who had localized symptoms. Men were excluded from uncomplicated UTI. They were automatic, men are automatically considered to have a complicated UTI because of the prostate. But now, any symptoms localized to the bladder is considered a uncomplicated UTI. And any symptoms which is beyond the bladder, like patients can have fever or other systemic signs, or patients can have like pyelonephritis with tenderness over the kidney, those are called complicated UTIs. This classification specifically excludes prostate infection. Prostate infection is different because it needs a longer duration of treatment and the approach might be different than a regular UTI. How do we approach what kind of an antibiotics we are going to use when we suspect? I think the same approach can be used for our kidney transplant patients. The four-step approach has been proposed by IDSA in selecting a better antimicrobial for UTI. First, once we suspect a patient has UTI, we have to evaluate the severity. How severe is the patient? Is the patient is in septic shock on pressors admitted to ICU, or is the patient septic but hemodynamically stable and admitted to a regular floor, or symptoms are just localized to the bladder, like patient has some dysuria, some discomfort, but nothing not symptomatic like sepsis. That's the first thing we have to do once we suspect like patient has UTI. If the patient is in septic shock, we have to evaluate, is this patient at risk for resistant organisms? This is easier because now with the EMR, we can go back on a patient's medical record and see, did the patient had any or like urine cultures in the past? What kind of organisms he or she grew, and are there any resistant organisms? It's always better to cover those organisms upfront when the patients are with sepsis and septic shock. Some patients can have like multi-drug resistant Klebsiella. In those patients, the first few doses of appropriate antibiotic will make a huge difference in the outcome. So when the patients are septic, you assess for the risk factors for resistant organisms. If there are no risk factors, but is a transplant patient, usually we go with a fourth generation cephalosporin like cefepime or piptazo, beta-lactamase inhibitor, or a carbapenem, which is also has good activity against a lot of resistant organisms. Again, this depends on the patient's allergies. Let's say if a patient is allergic to penicillin, you may have to choose cefepime or a carbapenem, for which the reaction will be much less. And then if the patient is in septic shock, once you decide the organism and antibiotic, you should also make sure patient does not has any obstructive pathologies. Once in a while, we see patients, they have hydronephrosis, like they hydronephrosis based on a CAT scan or ultrasound, or they have atonic bladder. So doing a imaging study will be helpful in in treating, providing appropriate intervention for the source control. If they have obstruction, usually a nephrostomy tube will be also helpful in the first few days, and then you continue the antibiotics. If a patient is not septic, then you can choose the antibiotics based on the local antibiogram. Uh, Local antibiogram is like every year, UH antibiotic stewardship releases the antibiogram. So based on that, you can decide whether to use a fluoroquinolone or augmentin or a cephalosporin. Most of the time, empiric treatment with fluoroquinolone is not recommended because a lot of organisms are resistant to fluoroquinolones. If a patient is asymptomatic and very minimal symptoms, you can consider fluoroquinolones. But if the patient is symptomatic with sepsis-like symptoms, then it's not better to consider fluoroquinolones. You can go with a ceftriaxone, cefepime, or piptazo, or one of those antibiotics. This slide explains the same things I mentioned. It's basically as preferred is cephalosporins, and the others probably are not going to use these highly broad spectrum antibiotics like cefiderocol. These are reserved for patients with carbapenem resistant organisms. Aminoglycosides are usually falling out of favor, but still they have a good activity against most of the resistant organisms. So in the first, we might use 1 or 2 doses of aminoglycosides also. And fluoroquinolones and Bactrim, most of our transplant patients, Bactrim is not an option because when they are on prophylaxis for 6 months, most of the bacteria are resistant to Bactrim. However, if they are off of Bactrim for 6 months or later on, you can still consider Bactrim. Bactrim is a good option for general population where they are not exposed to a lot of antibiotics. Fluoroquinolones based on the susceptibility and other agents include amoxicillin, clavulanic acid, or cephalexin, those kind of other antibiotics. And when do we switch IV antibiotics to oral antibiotics? And duration of therapy. This slide mentions the duration of therapy for general population. For transplant population, the duration of therapy has been not studied, but usually we tend to give a extended course of antibiotics, unlike the general population. So the first thing we need to see when to convert IV to oral. First, did the patient clinically improve? Usually it takes a couple of days, 2 or 3 days, depending on each patient. So once they clinically improve, when we say clinically improve, they should be able to tolerate oral intake and the patient should be afebrile and they should be comfortable going home. Then once they are clinically improved, then we need to assess what are the oral antibiotic options? This will be based on culture results. What did the urine culture, blood culture grow, and what are the antibiotics it is sensitive to? Based on that, we can make a decision. Patients' allergy risk plays a significant role in this transition to oral. Some patients have allergy to penicillins. Most of the patients say they are allergic, but in fact, they are not true allergies. So we can kind of dig into their allergy history and see like if they ever received any of the other penicillin antibiotics, then we can safely switch it to an oral penicillin. Treatment is generally recommended for 7 days in general population. Nowadays, in infectious diseases, there is a tendency to treat for shorter and shorter duration. If you asked a couple of years ago, in general population, pyelonephritis is treated for 2 weeks or maybe longer. But nowadays, we tend to treat it only for like 7 days, provided the patient is improving. If the patient is not improving, we cannot kind of say 7 days. We may have to extend the duration. And what if the patient is not improving? If the patient is cultures are growing on some organisms, patient is on appropriate antibiotics, but the patient is not improving, then we need to see what we are missing. Is it because we are not dosing the antibiotic properly, or patient has entirely a different infection, or there are certain organisms like Enterobacteriaceae, because first, second, and third generation antibiotics are not, cephalosporins are not recommended. So in those cases, we need to kind of go to a fourth generation or a carbapenem kind of an antibiotic. So once we switch it to oral antibiotic, we need to do a follow-up, make sure they are doing better, because it doesn't necessarily always mean that we give 7 days and all the patients will get better. There are some patients who might still have symptoms and they might get another UTI within a few days. In transplant population, usually we treat for 2 weeks, provided they continue to improve. Sometimes we may have to extend depending on patient's clinical status. There are some elderly patients who like septic shock. It took several days for them to improve. So in those situations, we may have to extend for much longer. One other, okay. So this is a slide which shows what antibiotics are. We can switch it to oral, like what oral antibiotics we can use. These are the most common, like amoxicillin, augmentin. And we have to dose it based on renal function. Among cephalosporins, the most common antibiotics we use are cephalexin and cefuroxime, and ciprofloxacin and like levofloxacin. Bactrim can also be used if the organism is susceptible. Generally, macrobid is not recommended to treat complicated UTI. You can use it to treat simple cystitis, but not a complicated UTI where there is a concern that kidney might be infected, because macrobid is not concentrated in the kidney. It is excreted in the kidney and achieves good concentrations in the bladder, but it is not effective to treat pyelonephritis. One other antibiotic we often use is fosfomycin. Uh, In patients who have resistant bacteria and in whom we want to avoid a PICC line or a midline or IV antibiotics, in those cases we can use fosfomycin. Again, this is not like a highly effective. In a case by case basis, we can use it. I did not put a slide for the prevention of recurrent UTI because a lot of patients have their own ideas about what to use, because on the internet, or they might have Googled on other websites, like even you might be asked about these other non-antibiotic approaches. From my standpoint, I usually recommend w- adequate hydration and emptying the bladder regularly. That's my go-to recommendation. Then the patients ask, what about cranberry juice? The studies on cranberry juice are like variable. Some studies show that okay, it's helpful, but then another study is performed, it says it's not helpful. So the data on cranberry juice is highly variable. My recommendation is if you want to drink juice and if you like it, you can drink it, but it may not prevent UTIs. And another approach is for patients, postmenopausal patients with atrophic vaginitis. If a patient is like 60, 70 plus, and then they have atrophic vaginitis, uh, estradiol cream can be used. Like you can apply estradiol cream to the vaginal mucosa that's supposed to regenerate like the epithelium and also have a normal flora. This has been this is practiced by a lot of OBGYN, and this is supposed this small studies have shown it might be efficacious. So if you're considering patient has atrophic vaginitis, you can use the estradiol cream. What about postcoital UTI? In younger women, if they say that like if the UTI is associated with sex, then a postcoital prophylaxis can be recommended, like an antibiotic like ciprofloxacin, Bactrim, or Macrobid after sex, and voiding after sex is helpful in preventing the UTI. And one other agent which is commonly used is methenamine hippuric acid. Again, the data on this is highly variable. A lot of urologists recommend it. The way it works is it's not an antibiotic, it's basically an antiseptic. Once we take methenamine in the bladder, in the presence of acidic pH, it's broken down into formaldehyde. Formaldehyde is a antiseptic. So this is supposed to prevent the colonization of the bladder and helpful in preventing the UTI. Again, the studies have variable outcomes, but there is no significant harm, I would believe, in recommending methenamine. Coming to the last approach, which I do is low dose antibiotic therapy. When do I recommend low dose antibiotic therapy to prevent UTI? I do not recommend this routinely for all the patients. The patients I choose are usually elderly patients who are being admitted to the hospital almost every month with bacteremia. It's not a simple UTI. They are usually admitted with sepsis. So in these patients, I recommend antibiotics, suppressive therapy. And the antibiotic we choose has to be based on what the culture grew in the past. If a person has some bacteria like E. coli, I choose the narrowest antibiotic based on the susceptibilities. Again, I educate the patients that being on prophylactic antibiotics does not prevent infections 100%. The purpose is to decrease the incidence if possible. So I inform the patient if they still have symptoms, they need to call my office or the coordinator because they might be developing resistant organisms. That's the drawback of a suppressive therapy. We use a simple antibiotic, the bacteria develops resistance, and they can have symptomatic UTI. And also the one of the common side effect will be developing C. diff infection. So if a patient has history of C. diff infection, I tend to avoid suppressive therapy. And usually after 3 to 6 months, I reassess the condition. And this is a shared decision making. I discuss with the patient, are they comfortable stopping the antibiotic? Some patients are usually the younger patients. Because I don't want to keep them on antibiotics for several years, they are pretty good in stopping the antibiotics and then following up to see if the UTI recurs or if the UTI is completely gone and they don't. If they have once in a while UTI, everyone can have it. So for that does not require a suppressive therapy. But I have a couple of patients, elderly patients, whom I have been trying to convince to stop the suppressive therapy, but they refuse. They said that I've been doing good with this suppressive therapy. I don't want to stop it. So sometimes it's difficult, and but shared decision making is very important in making a choice about the antibiotics. Okay, I cannot see the chat. Oh, shoot. Oh,
Hi, Dr. Gundelly. Thank you so much for your presentation. One real quick question that I have here is, with urinary tract infections, can that, like chronic urinary tract infections, can that cause someone's kidney disease to decline or get worse?
Yeah, it's especially even though some studies have shown like a variable outcome, but that's the bigger concern, especially if they have a real kidney infection like pyelonephritis in the first few months, 3 to 6 months after the transplant, they have graft dysfunction and the graft failure has been described. So that's one of the main reasons we try to avoid UTIs in the first few months, especially pyelonephritis.
Great, thank you. If there's any other questions, if you can put them in the question and answer. Um, and we just want to thank Dr. Gundelly for a great presentation understanding the urinary tract infections and kidney disease. Following this presentation, you will get a evaluation link to complete the evaluation. We ask that you complete these by next Friday. Certificates will be sent out next Friday. So all of you that participated will get a certificate. And next month, February 24th, we will be doing a webinar around pediatric dialysis patients transitioning to adult dialysis. So we encourage you to check that out. We'll be sending information via an email after the presentation, along with the video recording of this presentation. And we also want to remind people that our annual gala will be taking place March 7th. So for more information on that, please feel free to visit our website. And we look forward to seeing many of you on future webinars and presentations. Just got a question here. It says, can UTIs harm my new transplanted kidney? I think you addressed that a little bit, but obviously, if there's any more that you can elaborate on that.
Yeah, I mean, not just one UTI, because almost all kidney transplant patients will have UTI at some point after the transplant. But if someone is having frequent UTI with sepsis, especially because every time patient has a sepsis or even with directly the kidney being affected, it's going to cause fibrosis of the kidney. So definitely having a frequent UTI, symptomatic UTI will affect the long-term kidney function. So that's the reason we tend to prevent them if possible. If there is any structural abnormality or by giving antibiotics, we try to avoid those UTIs. But having one or two UTI because is not an issue.
Okay, great. Thank you. So if there are no other questions, again, we want to thank you, Doctor, for this enlightening presentation. And we will look forward to seeing everyone next month on our next webinar. Thank you,
Okay.
everybody, and have a good rest of the day.
Thank you, everyone. Bye-bye.